unforeseen complications due to COVID. Hypermature cataracts itself have come in huge numbers. Hypermature cataract itself the diagnosis itself is a complication which has come due to this COVID. We are seeing this in much more numbers than we've seen it earlier. Because of our lockdowns, all the electives were shut down and we could not plan. Nobody knew what was happening. All essential services were shut down. All ophthalmology services, elective surgeries at that time for the first few months, none of us were operating either. As per NPCB data, more than 5 lakh of surgeries, cataract surgeries done per month. So in the next 3 months of the initial lockdown, at least 15 to 17 lakh of surgeries would have been the backlog. As previously discussed in the same IC, there was a lot of apprehension by the patients and by us, the surgeons also. Ultimately, some surgeons went on to the extent of proving that there was no aerosol generated in a cataract surgery. However, for the patients, it was a huge economic impact. There was no paying capacity because there was no income for them, no public transport like Dr. KP has already mentioned. And also for the lower economic strata, there were no camps being conducted because we didn't want large number of people gathering. Hence, there was always going to be a delay in these in the cataracts. We started seeing hypermature cataracts, neovascular glaucoma with cataracts, as well as brown dense cataracts. This was highlighted by all media also that ophthalmology services have taken a big hit. Our last month's IJ also had this cover image saying a long wait due to COVID. Ultimately, we did start the camps. This is how we started the camps for the lower socioeconomic strata with proper social distancing. We made sure that everyone was wearing a mask. Our doctors and our other staff were also adequately protected to the extent possible. In the camps, like Dr. Satyajit already mentioned, we did a rationing. Mature cataracts were given preference. Patients with other ocular diseases, glaucoma and diabetic retinopathy, were also given preference. Finally, we go on to the OT scene. It's like any other hypermature cataract, nothing special about it, but we got these variety of cases. This is a video from my friend Dr. Naveen from Bangalore. This patient with a past keratoplasty, hypermature cataract there with a lot of synechiae, quite a difficult surgery, well managed by Dr. Naveen. Also, one more phacolytic glaucoma, fortunately presented early, and therefore as soon as we see once we enter the AC, everything gets clear and the good SICS could be performed. Now, we have few other surgeries. Again, like any hypermature cataract, my main fear in a hypermature cataract is the Argentinian flag sign. Without a good rhexis, there is no support for a sulcus implantation. And if I have an Argentinian flag in OT, that's the time when I start sweating. That is my most terrified thing. The most thing I'm terrified about is an Argentinian flag sign. Sometimes, yes, we do manage to nicely nick it and draw another rhexis all over it, and then complete a phaco and then in the bag IOL implantation itself. But we all know that we never know when the posterior extension can be there, when we'll be able to put an IOL in the sulcus or not. Here, as previously discussed, a small rhexis is being done and then it's being spiraled out. I think I'll just skip this because this is what all of us are doing. And we are doing many more numbers of these days because of the mature and hypermature cataracts that we've seen who were delayed because of the COVID. One more thing is phacomorphic glaucoma, Dr. KP has already mentioned. Other problems are endothelial cell loss because of the glaucoma as well as the inflammation, and not everyone could be done under peribulbar, under topical, and hence some complications might have arisen because of the peribulbar block. Some of us had forgotten how to give the peribulbar blocks in the age of topical phaco. We have also been seeing some patients coming back with aphakia from various centers because of their hypermaturity. Probably, I'm assuming it's because of their probability. So this will be one more thing we have to start doing, much more SFIOL or retrofixated IOLs. In literature, there has been a talk about immediate sequential bilateral cataract surgery as a response to the COVID pandemic, so that for patients this entails fewer visits. Therefore, they are not exposed to other patients and henceforth. But however, I don't think this is a good thing in our Indian scenario at least. So thank you, Dr. Satyajit. I've tried to cover what happened in the pandemic, hypermature cataracts per se in COVID. The numbers are much more, and it's like any other hypermature cataract. Thank you for this opportunity.